Okay. So today we'll discuss the linkage between behavioral and substance addictions. You notice I said discuss because it's more of a discussion topic. I will present some ideas, models, some analysis that I thought of, but it's much more of a theoretical discussion than will come up with any answers necessary. So the goals of the presentation today are to discuss first similarities and differences between substance and behavioral addictions. But very briefly, like theoretical difference, substance and differences, similarities and differences. Then to use Kuban-Velko's model of addiction to try to understand some of the similarities, perhaps differences between substance and behavioral addictions. Then to discuss studies that I thought about, some preliminary analysis that I did to address these questions, and studies that I didn't do to address these questions, and then whether or not we really care about addressing these questions. So quickly, first, just talk about what we mean when we say substance addictions. And in general, we use the same tools to diagnose, let's say, a substance use disorder. These are the DSM-5 criteria, which are basically the same across all substances. There's also the ICD-11 criteria. The idea is that the same set of criteria across all substances. You can see in this table that sometimes there are differences. For example, in the 11 DSM-5 criteria, at least 3 or 4 of them, tobacco is looked at a little bit differently. The truth is, I would say that nobody uses the DSM-5 for tobacco use disorder. I once actually submitted a manuscript to addiction DSM-5 tobacco. Somewhere else, but there is another, like for example, the Fagerstrom test for nicotine dependence is used.
How come?
It measures things basically like craving and withdrawal, like how much, I guess it's more, how come, that's what we'll get to here. Because those questions are more like, what exactly is nicotine doing in the brain, in the sense of how soon after waking up does somebody need a cigarette? Right. How much time, or which cigarette has more of an effect? It's more of the actual, I guess, the physiological dependence. I don't know. But I don't know if that's the reason, but people use it. Maybe because it works for treatment, that's what people use. Mm-hmm. Another thing to mention, withdrawal is definitely different across substances. And again, that gets to the biological differences between substances. That yes, substances work in different places in the brain. There's different receptors, there's different, but yet, even though there are those very specific, neurological differences, there's still some general thing called addiction that behaves the same. And the other thing to mention, which is relevant for some of our work, is that prescription medications, according to DSM-5, tolerance and withdrawal is going to happen when someone's taking prescription medications, even at the correct doses. So when you want to diagnose somebody with a disorder for prescription medication, you have to measure tolerance and withdrawal when you're using it not as prescribed. The idea is that you're doing something different than the doctor said, and therefore it can be counted towards a disorder. Otherwise, for prescription medication, everybody would have a disorder, because all you need is 2 criteria to get a disorder. So that's another thing to think about. So while we use the same criteria across the board for all substances, there are always differences that reflect that there's both the similarities and the differences. Now, in terms of behavioral addictions, it's a much bigger, I guess, issue in a sense. First of all, some behavioral addictions are defined using similar criteria to substances. For example, in DSM-5, gambling is defined as in the category of substance and behavioral addictions. ICD-11 also defines gaming related to substance use addictions. And then you have the next level, I guess, is disorders of behaviors. For example, sexual behaviors, which includes pornography, which is actually defined as a compulsive disorder. So we get to the question of what's the difference between addiction and a compulsion. Okay, and then we get to the next level of behaviors that we talk about: addictions, technology addictions, I don't know, food, exercise, anything you want. Vera will talk about cosmetic surgery addictions, very like where do we, how do we define a behavioral addiction? Where do we draw the line? Do we draw the line? Is anything that's done excessively, could that be an addiction? So that's really where our questions come in. Okay. Now, the Viewpoint article that I sent around, it was like the idea is to discuss the article, brings up the main problem that this article discusses is that we have this implicit assumption that we either just assume this without stating it, or explicit premise, we explicitly state that behavioral addictions are necessarily conditions of the same kind and quality as substance use disorders. So behavioral addictions are the same exact as substance use disorders. In what way are they the same exact? Well, they have the same biological underpinning, the same mechanism of development and so on. And therefore, what happens? Therefore, we can use the same exact measures. We take the DSM-5, let's say, criteria, and we just use them for whatever behavior we want. So that's the general problem this paper has. And the problem is that they also say, okay, here's some other issues. Any behavior can become excessive. So you basically over-pathologize daily lives. Anything's a problem, and you make actual addiction less important because everything can become an addiction. They complain that frequency of using something is a meaningless criteria. It's actually not a complaint because it's actually true also with substances. We don't, in the DSM-5, there's no measure of frequency of use of substance. The assist, for example, which we'll talk about, I'll show later the criteria. It is the first criteria, but we also, in our recent publication, everyone saw it in Frontiers Psychiatry, I don't know, whatever it was. We also show that frequency of use. Once you take, once you get past it, we get everything else matters much more than frequency of use, which is something that we could discuss separately, but it's a complaint that these authors are making, but it's true. I mean, it's meaningless. Across the board, we don't use frequency so much. And we could discuss that, but that's true for not using frequency for determining addiction. Okay. And the authors say instead, we need to focus on functional impairment and distress as indicators of psychopathology. It's actually an interesting point because if you go back to the DSM-5 criteria, there are some criteria listed there. There are distress. Social, you could say impairment, social impairment due to use, using in hazardous or physical, psychological problems due to misuse, but it's not a required criteria where you can say, well, as long as someone has 2 criteria or 4 for a moderate disorder, you don't have to have any distress to be diagnosed with a substance use disorder. Now, depression, for example, according to DSM-5, you have to have distress. You could count as many criteria, you can get all 9 criteria. If you don't say yes to distress or impairment, you do not get a diagnosis of depression.
Really?
Really?
Because when I diagnosed depression using
Right.
PHQ-9, which is
You don't
based on
need
it,
to check.
you don't check for that.
Right, so we're not diagnosing depression,
Okay.
it's a screen. It's also true, no, it's a good question. It's also true that many people in research, when they talk about DSM-5, even DSM-5 depression as a research tool, they will just count criteria and they will ignore that.
Mhm.
It's very common done in research because the idea that you have something called depression and almost like distress or impairment may be a different pathway in some sense. Like the idea is that, but for treatment, if you want to go in the States and you want to get your insurance to pay for your treatment and you actually need to get an official diagnosis, they won't treat people that aren't distressed, have no impairment, has no effect on your life. If you're getting up every day out of bed and you're going to work, they're not going to treat you for depression.
But that's function, that's not necessarily distress.
Right, okay, so let's talk about that. Functional impairment, okay, you're absolutely right.
Okay.
But it is, I think, an important question in terms of thinking about this, where these, and we'll come back to it maybe, but we'll come back to it somewhat. This, the authors are saying, in this case, for behavioral addictions, what's important is the impairment, like the consequences of the addiction, rather than the overuse addiction itself. And the authors further argue that if distress and impairment are what's important, well, that may be more related to personal social values, what's acceptable in the community than necessarily to the behavior itself. But that could also be true of substances. I think when, Orr was talking about the cannabis use, the medical cannabis use, criteria, the same question is some groups of people see things differently. So I guess the idea is we're trying to differentiate between substances and behaviors, and these authors are saying we can't just assume that behaviors act the same way as substances, because behaviors don't act in the brain. So you take psychotropic substances act in your brain, and to say that behaviors are doing the same thing, they say it's a leap. I think there are studies showing that certain behaviors, there are functional MRI studies showing that for certainly certain behaviors do affect the brain. So maybe it's not something in your body that's, actually binding to a receptor in the brain, but there could be behaviors that affect in the brain. So again, that's the question. And therefore the authors say that, talking about physiology, how the body responds to chronic behaviors is inappropriate. Unclear to me. I mean, certainly there's a difference. Certainly putting a substance into your body or using a behavior is different, but does it have an effect?
But when you talk about the sexual addiction,
It has an effect,
I
right?
mean,
Has a
it's
physiological
purely
effect.
biological, very strong effects. So even pornography, I mean, it has
Yeah, it has a
strong
physiological effect.
yeah, I mean,
Right.
so
yes, right. So I'm saying, here's what the author said. I didn't necessarily agree with him. And the last thing, I had to use the word reification because Moore uses it. I still don't know what it means. When you make something real, I guess that you're saying that these methods that we use for substance use disorders are something real in and of themselves. So like independent of the substance, but also could be applied to the behaviors. And the authors are complaining about it. And they say that therefore, once we do that and we take the same criteria for substances and behaviors, we're missing a lot of information. And we're not studying behavioral addictions correctly. Okay, so that's the viewpoint article. Again, I had some things I didn't agree with, but let's get back to the original question, therefore, is what is the same about behaviors and addictions? What is different? And what does it mean in terms of how we study them? And in terms of both research and in terms of both clinical approach. I'll talk more about the research approach first, and then we can talk more about the differences that make, Okay. Oh yeah, I'm sorry. So for solutions for behavioral addictions, they basically say to talk to people who have real impairments and excessive behavior and see what kind of symptoms they have. Think about putting behavioral addictions into the larger perspective of psychopathology, meaning are there in some sense more similar to addictions, or you could say compulsions, or even more similar to other psychopathology in some way. Okay, so that's their idea. But again, they're saying look at differences between what's unique about the behavioral addictions that's different from substances to use that information, which is not wrong. But to get back to the question about, well, what is its fame? Now, on the other side, you have this general idea, which is the addictive disorders all share an underlying biopsychological process. And this is where I say even before 2008, but this is a really actually nice study, a nice review of it. All these, we have this idea that all addictions are the same. In a sense, there's something underlying all addictions. There's something nice about an idea that there's similarities, because that means you can actually use the same methods. Back to what he said, it's simple. It's not simple in a good way, because people like to keep things organized. If you can organize things well in your mind, then it helps you. Looks clear. And you can, their mechanisms are involved are very similar. The association with common mental health disorders is similar across substance and behavioral. Of course, there's some differences, but there's a similar idea that they are associated. The risk and protective factors are similar. Family history, so there's a lot of similarities, and there's there's an idea, there is something in common. So we have to think about common and, similar and different. So in terms of thinking about the similarities, it's actually in the Frontiers in Psychiatry paper, one of the reviewer said, can you put this into like some general model of addiction? And I was like, no, what are you talking? And then I was like, okay, it actually was quite useful, because you never know, you always complain about, I was like, okay, I can put this into some general model of addiction. And then once I was looking at this model, I said, hey, this might actually help us think about this problem between similarities and differences. And the other thing that helped me think about this problem between similarities and differences between addiction, substances, and behavior is Orr's presentation. When you showed, and I'll come back to that yet, when you showed that you had criteria, the ones that you selected in the end for medical marijuana problems, and those were really, and I'll come back to that in a minute, how I got where we got to there. Okay, but I'm going ahead of myself, sorry. Okay, here we have a theoretical model of addiction, which I think is a very, well-known model. Basically, there's this cycle of, let's just say, withdrawal negative affect, where people have distress, and then they want to use, so you have the preoccupation, anticipation, they're thinking about using, they're craving use, and then there's the binge intoxication step of using the substance. And then when the substance effect starts to wear off, then they have withdrawal, negative affect, stress, and then they plan on using it again. And that's the basic idea. And notice also here that the use stage is called binge intoxication. It's not called use. So there's also this idea that, it's difference between what use and binge intoxication. We could talk about that in a sense, but that's you have overuse in some sense. And the use itself at high levels affects different brain regions, which affects different functionalities in the brain. See, those are the squares in whatever color it is, beige. Like differences in changes in reward systems, so that maybe the effect, like the tolerance, the effect of the substance can have less effect, or different kinds of changes. But the important thing I also wanted to talk about in this picture is the executive function place. So there's this core 3-step cycle of use, misuse, and then to treat, and then there's the withdrawal and stress, distress, and then the getting ready to use again, and then using, and so on. But there's also a connection to executive function. So in executive function, it's like it's general, large category of mental or emotional ability to make decisions, make appropriate choices. And the same region of the brain that's involved in executive function, they're saying, is involved in this cycle of substance or for addiction. So that addictions could impair decision-making and lead to behavioral disinhibition. And then you get things like deciding in some way, or not even deciding, just doing, using substances or using behaviors in ways that may not be most healthy or the most appropriate. So in terms of thinking about this cycle, in terms of the criteria for substance use addiction. So first, I think I was thinking about the DSM-5 criteria, which ones are like most related to these 3 core stages. So for example, you have in the binge intoxication stage, you might have using for a longer amount of time or larger amount than you would have anticipated, spending a lot of time using, or having difficulty controlling use. And then the withdrawal negative affect stage might be withdrawal. Tolerance, which might, you need to use more, or that can also be like tolerance is what leads to withdrawal when it takes, or it can also, tolerance could be thought of as binge intoxication, that you need to have more of the substance to get the same effect. Somewhat, or use despite physical or psychological problems is a question mark. I wasn't sure where to put that. It's all theoretical, because that could be you could have the psychological problems could be distress, or that could also be thought of as a consequence. We'll get there in a minute. And then we have preoccupation and anticipation stage, which is craving, like really wanting to use, and then time spent again, like planning how to get this, what you need, planning to use.
But the physical, psychological problems can be also part of intoxication.
Yes.
And in this model, everything begins with preoccupation.
I don't know. Theoretically, I guess it's a cycle.
Of course, but
Yes, if you could break the cycle at the craving point, then you could break the connection between distress and use.
But the craving point is necessary a distress component, a preoccupation component, something uneasy.
Good question.
I think the second they put in anticipation,
Could be
it's
triggered.
eliminating the need for craving. Saying, okay, I'm just anticipating.
It could be
not craving it, but I know I'll do it
I'll
this
do it,
afternoon.
right.
So
Or it could be like.
Because this preoccupation anticipation is assuming that all those addictions have a component, a basic component,
Okay.
that compensatory or something like this, the reward system that will compensate for some
something, right?
negative or aversive experiences.
Yeah.
Or you can assume that you are in a very well situation or very regulated situation and you want more.
Right, that's a good question. I don't, this is really just, theoretically, yes. In general, craving, they sometimes use preoccupation, anticipation, they sometimes even call it craving. So I think in this model, it is considered to be a core. But that could also be a philosophical, question about how important, what.
Because the preoccupation is the
Right.
preoccupation that the object or the substance will not be
Be
present.
present, and they have to try to get it. Okay, so then, and I thought of thinking, those were thinking about in terms of the core criteria that look at the three-stage site, those 3 steps, and I'm thinking about the consequence criteria a little bit separately. And in some ways, these could be related to executive function, that executive function domain that we mentioned before, being connected to the core, but outside of it, affecting it in different ways. A lot of these criteria, for example, you're using despite physical or psychological problems. So maybe you shouldn't be using because it's going to lead to a problem. You're neglecting your roles. You're not doing the things you have to do because you're using. You're having fights with, friends and family because you're using it in a dangerous way, and you're giving up activities to use. And that's what Or was showing, that when you showed the list of criteria that you got for medical cannabis, and there were basically consequence criteria. And Mario asked, what about all the ones we're used to saying about impaired control and, those kind of more core criteria? And you said you removed all the criteria that were related to alcohol and depression. So I said, well, maybe that's a hint to what could be going on. Maybe there are somehow like 2 sets of criteria. And the core criteria in some way are more based on the biology. And they perhaps are like more of the underlying cause that can be addressed in some level. And these may be more related across addictions because they all have some similar parts of the brain. And maybe they're more related to mental health disorders. As opposed to the consequence criteria that may be more based on social cultural constructs and lead to impairment and distress. That was my hypothesis, very broad idea. So what I tried to do is to go through each of the questionnaires that we have in the epidemiology data and to basically just try to through the criteria and decide, because these are the data that we have. It's not like best case like DSM-5, etc. Sort through and just see if I could categorize the criteria into these 2 groups. And so that would be the first step. So for example, in the assist that we use to measure problematic substance use, core would be frequency of use, craving, failure to control use. The consequences would be health, social, legal, economic problems, failure to fulfill roles. Now, and then you have something like others are concerned about your use. I have no idea where to put it. Okay, maybe there's a consequence. People are worried. It's not you, what you're doing. Put it there theoretically. I put out all of these, but we're not going through all of these. I tried to go through them and just I put down my own little, what do you call it, codes like LLs, larger, longer, and so on, to try to see how I could organize these. And as I was doing this, going through each of these screens and saying, well, how many of these actually seem to be built on the same idea? How many of these seem to be built on a different idea? More like what the paper was arguing, the question marks, or things that I had no idea where I would put them, because it's when you were gambling, did you go back a number of days later trying to make back what you lost? I don't know, maybe that's a reasonable thing to do if you're gambling. I don't know. Is that a consequence? Or does it mean that you're doing it more? Or did you feel guilty about the fact that you were gambling? I don't know why. Oh, I thought maybe that could be distress. But the point was really that there are a third category of items that were I don't know, that necessarily fit into this, paradigm.
Executive functions.
Executive functioning. So executive functioning, I'm considering to be consequences. So I try to.
It's they can't cut their losses.
You can't cut their losses. Right. So that's another way of thinking about it. Okay. But it's one of the issues that we'll discuss. So I have them for all gaming and for all of these. We don't have to go through each of them, but that's basically what I try to do. And you can see the sexual behavior questionnaire kind of fits in the same framework, where It's pretty simple to organize the 6 items into 2 categories. Gaming also was pretty simple. Social media also was pretty simple to organize. That's not a surprise because all these 3 questionnaires were written by the same group, more or less. They use the gaming questionnaire as a paradigm for the social media and for sexual behaviors. And so they wrote the questionnaires to match. So I don't know which came first, this is, if the questionnaires match, then they're assuming that they're like substances. That's what we have to work with. So here's the social media.
Can you please repeat what are the letters?
Oh, yeah, I'm sorry, I should, not, let's see, can I go back here? Yeah, so this is like my own code that I use for the DSM-5 criteria, just I should know for myself when I was trying to put them in. Like TS stands for time spent.
Right.
I'm happy to go through this with you if anybody wants to go through it. I just figured for a presentation, I'm not going through all of it. C is craving, neg F is negative affect, QC is quick control, and W is withdrawal, and R is neglect roles, but just to help myself organize them.
And then it touches the whole criteria and.
No, not necessarily, right? Because like DSM-5 has 11 criteria. This only has 6 items.
Okay.
That's a good question. Now, they just chose a few. We could discuss that as well, which is how do you measure addictive behaviors? Here we have pornography, and there's a longer list of items for pornography, and you actually get more coverage in this case. You get neglect roles, you get physical, using despite physical or psychological problems, you get using despite social and interpersonal problems, so you get a whole long list of items here. Internet, again, just many more criteria. You can see, but that was in general what I tried to do. I tried to first organize the items into these 2 categories. And then I said, so what am I going to do with these 2 categories? So what I did was I created scores from these 2 clusters. So instead of having one thing called internet problems, and I'll have something called internet core and internet con, I guess, for consequences. And my idea is now, are these differently related to other substances, other addiction, other behavior, behavioral addictions, mental health disorders, risk and protective factors. And I said that the first thing, of course, I want to use network analysis because that's what I do. Now, the reason why I like to use network analysis is because we know for sure if we would only put in, let's say, alcohol core and alcohol consequence criteria are highly related. So if you would only put in alcohol consequences by itself into an association, it will be related to anything the alcohol core is related to because it's highly related to alcohol. So the network analysis advantage is that it adjusts. By putting everything in at the same time, it says, do the alcohol consequence items score? Do they relate to other things? After adjusting out the effect of the alcohol core items. So it's a way of being able to include everything, but adjusting out to see where there's still unique effects remaining. Another idea is to look at what's common among the addictions using some sort of analysis. And that I didn't do, and we can come back to it later. I just wanted to mention that there. Okay, so this is what I did. Okay. So I just said, all right, let's look at the substances. Let's see. I threw them all in. What do we see here? All of these substances, ALK for alcohol, TOB for tobacco, CAN is cannabis, OP is prescription opioids, SED is sedatives, and STIM is prescription stimulants. What do we see? That if you go around, like cannabis core is related to tobacco core, tobacco core score related to alcohol, the additives to, then to stimulants. And then you can see stimulants, there's a line that goes to opioid core. So what this is showing is that the same thing is true of the consequences. This is showing on some level that across substances, all the core criteria are related and all the consequence criteria are related, which is interesting, maybe. That's what I predicted would happen. But all this information is really coming from people who are using more than one substance. Now, I don't really know how well somebody can tell you that the consequences of their behavior is from alcohol and not from, maybe cannabis and tobacco. Can somebody actually differentiate between, consequences of their behavior from 2 different substances? Or even the core substances. Can somebody, craving, can somebody differentiate between, I have no idea, I don't know. Can someone differentiate between craving which substance they're going to crave? Now, it may depend on the trigger, on the environment. What I'm saying is that it could be real, that really these core items are more related because they're all involved in the brain. And really the consequence items are all related because they're related to how somebody deals with their distress. Or it could be that people are saying yes to craving to both substances that they use because they're not differentiating between the two different cravings. That's my, how do you interpret these results? Here's the same thing. I should have put instead of the shortened version name of the thing. I should have told you what it was on the slide. But PGSI is gambling. See how well you know these questions.
I know, yeah.
Matter. The point is that core and con, PGSI is gambling, GIS is gaming, PPUS is pornography, BYSAS, sexual behaviors, BSMAS, social media, and IAT is internet. And again, what we're looking for is, do you see connections between across addictions? Are you seeing connections between the consequences or between the core items? And again, we're seeing connections between the core. Now, it's not perfect here. Like, for example, you can see that GIS core is related to internet consequences. But in general, gaming core is related to sexual behavior core, which is related to social media core, which is related to internet core. It's not surprising that gambling seems to be a little bit different because gambling is actually highly related to substances.
Yeah, it should
And
be
therefore
the
what?
previous.
Previous one. It should be on the previous one. Therefore, what I'm not sure.
There's also gender interaction.
Yeah.
That aren't in the other ones, maybe either.
This is a very basic idea. Do we see more similarities between the core items and the consequence items? We kind of assume that we do. Now, what to make of this, we'll discuss. But kind of seem like there could be something going on there. Again, given the same caveats, can you tell craving differences? Can you tell consequence differences when you're using multiple things?
Dvora,
Yeah,
is it possible physically to conduct research with people only using one substance or having one behavioral addiction? So
And
that you
then
can like
trying to
isolate the effect of each one?
Then you won't have any connections.
comparison.
Rashomati?
You won't have any connections.
You can't.
Like the connections are-
Connections are dependent on people who use them. Who use many things.
But all the findings are driven by most of the participants not using.
Not using. Okay, that's true
Or
too.
not.
Not having high
those-
scores, having low scores for most
Low
stuff,
scores.
for low scores for most.
Right.
Yeah, yeah. Most people don't use. Most people, depends which ones we're talking about. Yeah, sort of like tobacco is.
No, it's
Yes,
behavioral
yes,
addiction.
behavioral addiction. Most people, right, most people don't. People are related because they're all of zero.
Because I gave before that it's really a problem to kind of like distinguish which effect for
Yes,
which
for which
addiction.
substance, yeah, which addiction.
substance or behavior.
Exactly. For sure. And here, I combined looking at all the different kinds of addictions. In this figure, I only included the connections that are cross-category. So I'm only including connections that are cross between a substance and a behavior. So you don't see all those extra lines between each of their, between all the substances that are related, and all the behaviors are related, and they're all related, all the cores and cons are related for each. But here again, we're seeing something like sedative core items is related to social media core items. That's related to social media core items, is related to alcohol core items. And alcohol core items is related, then you have a problem there because, alcohol core items is related to the sexual behavior core items. Then you look at something like this, alcohol core items is negative related to pornography consequences. I have no idea what that means anyway. But again, see, pornography is related to consequences, related to alcohol consequences, related to gambling consequences. So you see, again, we do see kind of like a consequence cluster and a core cluster. So those are basically what I started to do in terms of this. And then I said, okay, let me look at these core and these items and how are they related to risk factors. So for example, I put in October 7th exposure. And October 7th exposure was very much to the core consequences for various things, which I didn't show you. But then I started looking at like actual use, the use and misuse. But then I looked at things like childhood maltreatment, ongoing stress. And there it depends. It was mixed. It wasn't like this is only related to the core items only related to the consequences. Here's the mental health disorders that I put in. And again, here I'm only showing connections that are between mental health disorders and substance measures. And you can see that, yes, PCL, which is the PTSD, is actually related to core items for stimulants, core items for alcohol, core items for sedatives, but also consequences for alcohol. Anxiety is related to core items for sedatives, and depression is related to core items for sedatives.
So they are related more to the misuse,
Yeah, yeah,
not to the negative
not to the
consequences.
consequences, which is what Orr showed when she showed her items as well. And the ones that were related to depression,
But
she
you
threw
will
out.
you will expect that should be related more to the negative consequences because it's more distress.
Or it's,
I think there's two types of consequences. There's like the direct consequences from the
from the use,
use.
and that's the
There's,
stress.
and there's the consequences of not using, which is, let's say, when I'm at PTSD and I'm not using, then the consequences is that I have more symptoms.
Have more symptoms.
Right,
Yeah,
and
yeah,
maybe
yeah.
there's like a way to like take that into account.
And the other way is that the self-medication model.
This is self-medication model.
That you have more of
Yeah,
the
this is
stress and you use more.
Or distress or use. Yeah,
Right,
And
and so
go more with the self-medication.
Yeah.
And not with the distress.
well, the consequences, right, the stress.
but even theoretically, like if you're thinking about, let's say, like behavioral addictions, like it's harder to say that you have some chemical that's, creating dependency. So what's creating dependency? That they have negative consequences of not using
Of
it,
not using,
right?
talk about that, yes.
Although we do know that there are chemicals,
not from-
everything goes through the brain.
Yeah,
So the
but-
point is that the behavior could also, the behavior causes other chemicals, neurotransmitters to be, and then the behavior does have an effect on the brain, just the chemicals aren't ingested, they're just.
Not as strong.
Not
Or it just creates more stress in my life.
not using. And the same thing here I showed with the behaviors and mental health disorders, where you can see that depression is associated with the core items for internet use, pornography, and gaming. Anxiety with the core items for gaming, but with the consequence items, both negatively associated with consequences. And then the PTSD with the core items of social media use, but with the consequences of sexual behavior. So it's
But
not
also more with the core.
more. That was the general idea. Okay, now that was, and like I said, the mental health, the other risk factors I looked at. October 7th, yes, seem more of like a, just a self-medication theory, and the other things not necessarily consistent. So there are many limitations to what I just presented. The first thing is I made it like, I actually looked online to see, like searched to see if there's anything that takes this Kuban-Valkal model and like try to put all the criteria in certain categories like I did, and there was nothing out there. So I just did it on my own, like by thinking what I thought made sense. Now, we don't know how well these criteria assess these two categories that I made up. And the second thing is I like things like neglect roles or activity given up. I put them in the consequence category, but they could also be related to stage 2. Stage 2 of this 3-stage cycle is distress, right? Withdrawal distress. And part of that is considered to be a decreased reward. So there's a lack of motivation to do non-addiction activities, lack of motivation to do other activities. So this whole idea of putting things in 2 categories, a lot of the things overlap. We don't necessarily even know if these are good, categories. Second thing is, if we noticed, a lot of the screens have very poor information on consequences, like asks altogether. Did you have any problems with legal problems, money problems, friends problems, health problems? If we really want to consider consequences as like impairment, functional impairment in all different areas, then we would have to ask much better questions about functional impairment in all different areas. And the categories, again, can actually be connected. And the consequences may actually also indicate just more severe core problems. That somebody is using so much, they're going to have more consequences. It doesn't have to be a separate category. It could be both. Now, in terms of just getting back to the paper that we reviewed, what I would say that this paper argues that the core items may not be as relevant for behaviors, may or may not be true. And that try to put it in a different, they are suggested putting into a different psychopathology category. So is there a difference between addictive behaviors and compulsive behaviors? Is there a difference in how compulsions work in the brain? And therefore, if there's a difference, for example, like sexual behaviors and ICD is a compulsive behavior. If there's a difference, then does that affect how we do research on these different things? Does it affect? So another idea I was just thinking about in terms of thinking about these consequences or thinking about the differences perhaps between substances, between addictions and substances and behaviors is then consequences is thought of as using despite negative outcomes, some sense. You know, you're using it, especially in the DSM-5, categorization, using it despite it being hazardous to your health, like smoking in bed, despite the fact that you can set your bed on fire. Using, I don't know, using despite, having arguments with your family about your use, using despite, whatever. Now, using despite is related to executive or cognitive functioning, in a sense of being able to understand that what I'm doing now is going to have a future consequence. Just had a discussion with Maura about this, and we were talking about the fact that the peak risk for use and addiction, for substance use, I'm not sure about behaviors, but for substance and addictions is teenage to young adult, where the executive functioning or the brain is still developing. So, maybe just all these are disorders of teen young adults now, that there's the idea that so maybe there's like an ability to make a risk benefit analysis as Mario mentioned, as Baruch mentioned, maybe using is the right thing to do in this situation. If you're not going to do it, you're going to be under even more distress. The sense of the self-medication theory, in a sense, is that using to self-medicate for distress is a maladaptive way of coping. And that's, because it messes with the brain, messes with the mechanism, and causes all these different problems. But there are also many, many other ways to look at, substance and behavioral addictions, use. It could be adaptive coping. It could be this in terms of risk-benefit analysis. This is a good thing for me to do right now. The arguments in the States, they're talking about how they want to raise prices or keep raising prices on tobacco, on cigarettes. And we now see like cigarette smoking in the States have gone down over the past years, except among people who have psychiatric disorders. If people have psychiatric disorders, they're going to smoke no matter what. So the argument is not ethical to raise cigarette prices too much, because the people who are going to smoke no matter what are just going to suffer more. And people who have severe psychiatric disorders tend to be, other issues, socioeconomic issues. So you're just going to hit them more. It's not going to solve their problem, because anybody who's already going to stop because you raise the prices is already stopping or slowing down. And for these people, there's something adaptive about smoking. Like, this is what they need to do to treat their disorder for whatever reason. So is it ethical? Sometimes, there's this idea that, using or,
Maybe they'd be better off if they didn't start smoking.
this is the counterfactual. You can find the counterfactual. They didn't start smoking, they would be better off, but they did. They did.
There were no
If there were no cigarettes in the world, they would use something else, right? Not to discard, we discussed this in a previous talk, not to discard the pleasure and enjoyment aspect of behavior as social activity, value in the activity. So I think that, we're very focused on this maladaptive coping, self-medication paradigm, because that's what you can tell me, like in treatment, in the clinic, that's what matters. Most people, you have to, that's where you're getting to eventually. Question is what to do with everything else. So in a summary, so I tried to talk a little bit about how similar substances and behavioral addictions, similar, how different, with the idea of thinking about core items versus consequence or executive function items. Tried to do a little bit of analysis to try to think about some way, and there's something that's there in this idea. Came up with a lot of limitations in terms of what our data could show. I still think there might be something there that can be worked out, not with the epidemiology data set, given what you know. But in terms of just the idea that cognitive functioning is very strongly related to to behaviors and to addictions. This work that I've done on cognitive functioning is using self-report measures. For example, we did a study showing in the NESARC, which is this massive study in the US on national representative data, looking at cognitive functioning items related to substance addiction. The self-report items are bad. We still show something for what it's worth, but I did another study recently. When I was when I was working at Columbia, looking at the difference between opioid medication for opioid addictions and also effect on cognitive functioning and self-reports. And they're just bad. So I'm not suggesting that you put any sort of self-report cognitive functioning measures into any epidemiology study. But for all you experimentalists, if there's any sort of cognitive functioning experiments that can be done in the lab, that's useful. I mean, I know there are. I don't know anything about them. In some way, if that's something that can be considered.
But theoretically, they could relate to both core
Yeah,
and
and core and
consequences.
Theoretically.
We have the
Mhm.
difficulties
Emotional
in emotional
regulation.
regulation.
That's like executive
I
function.
bet that's related to both.
It's related to both, yeah, more or less. Some more. So I mean, just something to think about. If we do, I never suggested putting cognitive functioning into a self-report, but it definitely is. When we think of executive functioning meaning be able to make decisions about what's
Affect both.
the question, does it affect one more than the other?
Question, I wanted to ask if you have, maybe there are certain people that would have more of one difficulty rather than the other, like maybe men and women, or.
It's very possible, yes. The example I like to give, yes, you say, so there's the core items. Somebody could, but I might say neglect roles. The example they always give is that maybe women women who are mothers will take care of their children regardless of how much they're using.
Yeah, so they will show only core.
So they will only show core, but they won't, and it comes back again to the question that Inav asked about the functionality. That the functioning. That is a more of like so somehow we want to like try to think of it as like core, how these things actually affect people's brain, but like in more general, like, you know, everyone's brain is affected the same way, let's say. But then the consequence, like the impairment, the functioning, is that dependent on social, cultural? It comes back to the question about the differences again. So I think there is something interesting here. How to get at it is a hard problem. The other thing I wanted to talk about also is just this shared versus unique variance. And what I mean by that is that there are another way to think about looking at it. All our substances, all our behaviors, how much is actually in common between all of these things? How much is not in common between all these things? And then you could say, you know, is the shared part more related to this? Is the unshared part? So it's like without a theory, you're not saying the core versus consequence, saying just throw out everything. We have no theory. We think there's something underlying all these addictions, and something not. And then is the shared, you know, more related to mental health disorders, to traumas, to things.
So maybe it's more the core. It's more the wanting, and the consequences is more my control abilities. So it's more like it's the craving and the ability to control the craving. Maybe these are the two factors that we're talking about.
The ability to control the craving is dependent on.
For some people may be more like, oh, I always want this, I want this,
Right,
but I can control myself.
Because I know that it's not good for me. It will. So this comes back to the consequence. That is my idea. Like there is, whether or not it's true, just, you know, but in terms of sharing the unique variants, again, in that case, we could do studies. But what's the same, what's different? But we're not going to get at what's driving the similarities and what's driving the differences, because we're not breaking apart the scales. We're just saying there's something shared, something not shared. Now, this I think is actually something interesting anyway. It's like a little bit off topic, but the reason is that, for example, when we were looking, or you were showing something to me where something was related to every one of the different outcomes. I don't know what it was. Related to all these
studies.
all your
That's
studies.
what I do.
Attachment is related to all the addictions uniquely.
And everything.
The addictions related uniquely. I'm sorry, it's everything. If you do an association and you say, is PTSD related to anxiety? Yes.
Everything.
Is it alcohol related to attachment? Yes. Is the social media user related to attachment? Yes. And the question is, are they uniquely? Is it uniquely related to each of them? So it might be interesting to, instead of, in terms of that perspective, instead of saying attachment is related to each of these outcomes, maybe say attachment related to the shared part across all addictions, or to something unique about specific addictions or mental health disorders. And that just might get you some more information, something might be interesting to think about in terms of, when you look at outcomes, instead of having 15 different outcomes, can we like kind of narrow it down to the shared part versus the unique part? And would that be more informative than just saying, PTSD is related
To the core part or to the.
See, the problem that I have is with that is that in the epidemiology study, I don't think this. I don't have enough data. I don't think there's enough evidence to be able to say, we have these two different parts, the wanting versus control, or the core versus the consequence. We don't, and we can categorize them nicely, and here they are. To be able to say, therefore, I guess with shared versus unique variance, you could try to do that. I guess you could try to take the chords,
Maybe you also need more behavioral addictions which aren't considered today as behavioral addictions.
just to add everything that you could ever do.
Right, and then because maybe that's like what's missing. In order
I
to
think
see
that
the
aren't
difference.
pathology.
Yeah.
If you work all the
That
time,
was like, that's your hypothesis, is that,
there's something that. I mean,
Yeah.
and then you're assessing
we're
the
trying
things
to
that are more like.
But it's true, the question, it comes back to the question, can every behavior become an addiction? Or compulsion, or is there a difference, or do we care? If you do something worthwhile and you're addicted, all the better, keep doing it. I don't know.
No, I like the idea of core, of this kind of craving, use and consequences, because when you are reaching treatment, you are reaching because of the consequences, not because of you are using, because you are using and no consequence, so you can continue to use. But it's the issue of prevention here, how to identify when the use become maladaptive and create those negative consequences. And so, and we have, if we take one, an example of one addiction in our epidemiological studies and follow up through the 5 waves of measurement and analyze only the use
Something, how it changes.
and how change the negative consequences through time. If you can, this together with other factors, risk factors, can create this kind of negative consequences. Because as you saw in the motivations, there are more the self-medication, the coping mechanism that may create some platform for those negative consequences. But there are those social uses or value of the activities or that perhaps will not bring to those negative consequences, or the issue of having strong self-control skills or not as a risk factor or protective factor, and you can keep the use without any negative consequence. So you can analyze. For example, if you take attachment, if I will take attachment anxiety, I will predict that attachment anxiety will be related specifically with the core. Like what you found, but with the core, but because of the problems in self-control and emotion regulation, so those core will at the end eventually go to negative consequences.
Right, we can look.
And so this is why in your network analysis, I think the GAD, the PHQ, and the PCL are related to the core components and not to the consequences, because the consequences are related to the core.
The core, right, there's
and not unique to the distress. So you can have here, it's cross-sectional, like you can have a cycle of distress or anxiety, and then using more, and this misuse can create those negative consequences that create more distress and more use and the cycle. But you can study those cycles, because then the prevention will be known the negative consequences, but more in the use when you don't have those necessary skills to control. And so you need to identify those guys and then convince them not to
Convince them not
use.
to use. No, that's an
Or-
excellent point.
Or compensate in a more adaptive way, or treat their problems and not.
Right, right.
Uh,
No, but Mario also made a point, that's an excellent point, that the consequences, meaning if somebody's neglecting roles or whatever, and despite, and still using, that itself can lead to more distress and back into that core cycle. So it's definitely all connected. So it's hard to separate things that are all connected
Yeah, but
as you have over
they are
time.
not uniquely.
Not
with,
uniquely related.
PCL,
Right.
PCL and GAT and PHQ
Right.
are related to.
To the core.
The core, the use.
These. And also that, sorry, 1 minute, that the you'll come, like I said, people will come for treatment in terms of because of the impairment and the stress, but when they're being treated, they're treated for the use, right? So you have to get back to the core, but prevention, where can you put the prevention in? If, maybe the prevention, like for example, is with some substances, people are gonna use people are using substances. The question is, then the prevention can become in terms of making, executive functioning, making choices despite the stress, using other forms of.
Yeah.
Yeah, sorry.
Maybe I'm far behind and you said it's connected to what Mario asked. Are there any examples of, I don't know, some people answering about the consequences criteria and about the core criteria? Because for me,
Possible, it's very possible, and it probably is. I just, I didn't, look for everything, but in terms of treatment, in terms of what really actually matters in the end, is going to be the impairment.
the core.
In a sense, the consequences, how impaired somebody is where, but in terms of, it's hard to differentiate.
No, but can you say someone has a quick
Yeah, addiction. It's fine.
Addiction,
You can
sorry.
ask in Hebrew, it's fine, I understand Hebrew.
has an addiction basically only on
Only consequences, but
on the
yes,
consequences?
yes, see, that's the problem with DSM-5,
Mhm.
has 11 criteria.
Right.
They only need is 2 to get a mild disorder, or 4 for a moderate, but either way, somebody could only have the consequences criteria and get a diagnosis. But it's not,
Right.
it's very rare for that to happen. Because if you look, you can actually look at, there are, see which are like hazardous use, like using despite risk being, using despite being hazardous, it's very rare for someone to
So
say.
there are some cases like, I don't know, binge drinking, which is classic for rush consequences, but it can be only twice a month, and then you are really low on the core, but you are.
So that's an excellent point. So that's a good
really
point. You're
high
saying,
on
we can look
consequences.
at people who just have score high in the consequences and seeing if there are people like that and what that, look, they're gonna still have to score high most likely on the frequency, but low on craving, lower on impaired control and higher on the consequences.
But then maybe it's a question if it's a compulsive rather
If
than.
there is no craving.
And you
Just not
can
craving,
tell from
right.
that, because you can have someone that just doesn't know how to drink and have bad consequences in his own experience, and someone that has binge drinking problem. And you can differentiate them using those, but there's so little part of the sample that it doesn't really matter for this analysis.
Okay, we think, yeah, the ways to think about it, it's excellent point. Ways to think about it. I definitely think that you see a lot of these, the DSM, a lot of the questionnaires that we have for behaviors ask, it's not less about consequences and more about, so we're kind of missing some.
I think the core question here is, what is addiction? But do we define addiction as consequences or core, or is it has to be a combination? Because if it's a specific process of the brain, then it has to include all the criteria for that. And as long as you don't define what addiction is, then you can say, yeah, it could be defined by the consequence. Like the cutoff is random. It has the cutoff for like points to get diagnosed as addicted to something has nothing to do with what we define as addiction. Like if it's some kind of rewiring in the brain or whatever, then those consequences don't measure it. Maybe craving, I don't know, maybe yes, maybe no. Like maybe it's a better reflection of and you cannot use at all. You can say, okay, I'm craving, but I'm not using. Are you addicted or not? Like someone who was addicted to alcohol but didn't use for the past 10 years, and someone that is regularly using, but is not craving who.
Because they're using regularly.
Yeah. So
They're not gonna be
who is
addicted.
addicted
Who's addicted?
to? It depends on your definition for what addiction is. And many times
It's combined.
lacks the core definition of what addiction is.
All the 12 steps, and so it's a matter of use, nothing.
Nothing else.
Problematic use, that's why we call it problematic use rather than addiction.
But we do, but it doesn't matter because we're still mixing the use and the consequences. We can call it what we want.
Yeah.
Because even if you were ever have the problematic use, even if you stop,
You stop.
you're still addicted.
Because you're at risk for you're at risk for relapse.
Mhm.
You're still at risk.
But do you think in other pathologies, like this general anxiety disorder, I think you have the same
Type of thing.
this issue, for example, you can have a lot of anxieties and fears and worries about being in a social situation and still being well regulated or don't think you have any negative consequences. Then you become social anxiety disorder when these fears, worries, preoccupations so create some negative consequences for your functioning, or other people are telling to you in the same way, I think, or the same with obsessions and compulsions, and also with eating disorders, or with even depression, because you can be sad and you can have lack of appetite or not sleep well, but still you can regulate and it doesn't have any negative consequences. So if we will ask people here, how well are you sleeping? How well are you eating? How well are your moods? So many of them will not be very good, but not you cannot see that they are depressed.
Right, so the question
And the
is,
same thing in PTSD, and this is why in the DSM-4 they added the functioning impairment. To be
Impairment.
diagnosed as a PTSD,
Yeah,
it's
you also
not
have
a
to-
matter of intrusions or avoidance or hyperarousal, it's also
Okay.
the functioning impairment.
but that's how addictions differ. Because addictions, they combine both.
Yeah,
So somebody can actually have addiction without having an impairment.
yeah. But
Does that make sense?
In PTSD, you need.
Yeah, right,
the
exactly.
different criteria.
So maybe we could suggest that a recent paper they suggested have something called pre-addiction, which is the misuse and the impaired control over use as a separate diagnosis, like, I don't know, that diagnosis, a separate category. And the addiction is when it has consequences.
No, but we have here thousands of people.
People, all different things that we
In
could look at.
those epidemiological studies that we can study these issues of pre-addiction.
Pre-addiction, we could look at this separate items separately,
Yeah.
see which items predict other items. But
Like the at-risk individuals.
that's just gonna do this, but we probably would need more than a year.
I really liked what he said about the pre-addiction. I don't know if there's any literature about it, but like, for me, it was like, oh, maybe it's not a binary thing, maybe it's more continuous.
It is
addiction.
continuous, that's also true.
Yeah, so
Yes,
that's just.
yes, definitely, everyone feels there's a spectrum
Mm-hmm.
of, how many criteria people.
But you don't actually, I'm asking because I don't know,
Yeah.
do you actually diagnose someone with like highly addictive to something or low? Like,
Problem.
you don't have that.
Let's say, for
That's
example,
the question.
one of the problems with DSM-5 is you have all these 11 criteria, they're all equal.
Mhm.
Basically, the way you do, you count how many criteria somebody says yes to, and you give them, and you say, okay, if they have 2 criteria, they're mild, if they have 4, they're moderate, if they're 6, they're severe.
But do you
Doesn't matter
categorize
which ones, no, it doesn't matter which criteria they're.
But you do have this kind of continuity.
Yeah, but not in, what you're saying is developmental, it's a developmental continuity. First comes criteria A, then comes B, and then comes C. So somebody could be put on this continuum of how things develop, change over time.
I see.
And what they do is no, they just count all of them. So it's continuous in the sense of if you have 2 criteria, then you're probably less severe than if you have 6. But what if the 2 criteria are the most severe criteria? Part of it, most of the time, people, when they really see consequences, they really also have the other criteria.
It's very odd.
But,
like that.
yeah, but it's good, but you'd have to follow people from the time they start using more or less. Until, to see the development. That's one of the fields now, in terms of even network analysis, it actually can be used to, over time, can be used to put the criteria in an order. First comes this, then comes that, and then comes that to tell you about the development of disorder. So that's exactly, it comes down to that. See if, you know, these things. Good, thank you.
Thank you.
How do I stop the? Okay,
Stop recording.
stop the recording.